All right, now we're going to move on to the last section, talking about standardized tests or assessments in the pediatric population. As PTAs, it depends. You may or may not be doing these, but you do need to be familiar with what some of them are and kind of recognize them. If you end up working in a pediatric setting, your PT might ask you to do a few items on a test or something like that. You can complete an assessment. Usually the scoring and definitely the interpretation of that test would be up to the physical therapist, and then the reporting of that interpretation and score would also be the physical therapist's job. But you as a PTA can still administer these tests just like you can do a Berg balance assessment, those kind of things. But in terms of telling a parent your child is delayed, you would want the PT to be able to do that. So some of these we'll go into a little bit more depth on a couple of them, maybe in lab and have you practice some, but a lot of them really you just need to know what the test is. You just need to know what age range it is and why you would use it, when you would use it, those kind of things. So anything you need to know about them, just refer back to the slides. We'll, like I said, go into a little bit more depth on some more than others. So when we talk about standardized tests, there's two different kinds. You can have a norm reference or a criterion referenced. A norm reference test is going to be comparing that child that you are doing the assessment on to typically developing or normal children. So we are comparing age-matched peers to that specific child. I'm not going to expect a 2-year-old to be able to do what a 5-year-old can do, but I am going to compare them to other 2-year-olds to say, they are typically developing, or they're advanced, or they're delayed. A criterion reference test is much more, you think about do a math test, you get a 70% or a 90%. It is a total score percentage out of the total possible points that you could get. Some tests are both. You can use their base score as progress against themselves. So you did it when they're 3 months old, 6 months old, 9 months old, and you're comparing their own score and their progress to that child consistently. But then maybe you're also comparing their score to typically developing kids to say when they were 3 months old, they were delayed, but when they were 6 months old, now they're at the 50th percentile, they're right where they should be in comparison to their peers. At 9 months old, well, geez, they've made even more progress. Now they're advanced. They're doing more than a 9-month-old, is typically doing. So some tests do both, but you do need to know the difference between a norm referenced and a criterion referenced test. Sometimes also insurance will want more of a norm reference type test depending on the kid, because that's how we prove that they're not doing what they should be doing. It gives us reason to say, hey, if we let them go now, they're not going to be able to keep up with their peers, they're going to be behind in school, etc. They need to continue in therapy, and this is my justification, not just they scored a 60% last time, now they scored a 70%. It's not great, but they did better. So insurance could say, okay, well, that's good enough. They made progress, they met goals, they're done. So screening tools you would use, they're much more of a surface type of assessment, not going super in depth, but you would use them to assess for delays. So if a child does not have a known diagnosis or disorder, this is when you're going to use a screening tool. The AIMS, or the Alberta Infant Motor Scale, is a little bit of a not normal one because it can be both a screening tool or its own standardized assessment that you could use with kids that do have a disorder. But the Denver and the Bailey, they're just going to tell you that a child has a delay, not that it has this, they have this diagnosis or not. But you wouldn't specifically use it on kids that you already know have a delay because it's not going to tell you anything new. So the Denver 2, basically second edition, the purpose of that is to detect potential developmental problems in young kids and then monitor those kids who are at risk. Age range, so kids that you could do this on and compare, this is a norm referenced test because it's comparing them to their age-matched peers. You could use it on any kiddo from 1 week old to 6.5 years of old or years age. You can correct for or should correct for prematurity up to 2 years old. In the next lecture, we're going to go over how to calculate age and correct for prematurity, but we don't expect a baby that was born at 28 weeks gestational age. They're 12 weeks early. They should still have 3 more months to develop inside the womb. We don't expect that baby to be able to do what a normal newborn does, or even when they're 3 months old, we don't expect them to be able to do what a normal 3-month-old can do. We expect them to be able to do what a normal brand new newborn term baby can do. So we give them that leeway. For the Denver, you give them that leeway up until 2 years old. It tests areas looking at personal, social, fine motor, language, and gross motor areas, and it has 5 subjective test behavior items so that you can say this child was very participatory, followed directions, or they just refused everything, or they were having a hard time, they were crying the entire time. So it gives you a little bit of a subjective way to quantify their participation based on how they acted during the test. The next slide will give you kind of a picture of what the scoring sheet looks like, but you draw a vertical line on that sheet at whatever age they're at, and their results are based on how many items they can successfully do that cross that quote age line. And so individual items, if they can do things to the right of that age line, they're advanced or normal. If they can do things that cross the age line, if they cannot do things to the left side, so things that you would expect a younger child to be able to do, that's caution or delayed. And then the test with all of those things in those different areas added up together can be normal, suspect, or untestable. So this gives you a picture of, very small picture, sorry, of what the Denver looks like. It's not my favorite test because it really only gives you about 2 delayed items before they say that the child is delayed, and that can be in multiple areas. If a child refuses to do 1 or 2 items, automatically it says they're either delayed or you should redo the test, that you couldn't test it or score it well because they just didn't participate enough. So it's very sensitive. It's going to pick up delay very, very quickly. You're going to get a lot of false positives saying that a lot of kids are delayed when they're not, just maybe it was a bad day for them, but it's not very specific. It's not going to tell you what specific areas the child has delay in, or you're going to need another test to really tease that out. The picture on the right is just a picture of the kit. There's certain items, the blocks, the baby doll, the rattle, those kind of things. There's a ball in there that you use to administer the test. So the Bailey is now in the 3rd edition. Its purpose is to identify any developmental delay and then again monitor a child's development as they get older. So you can give this test anywhere from 1 month of age up to 42 months, so 3.5 years old, and then the areas that it looks at are a mental section, motor section, language, and then behavior. And this is also a norm referenced test. That's a picture of the kit. There's a specific scoring book and the items in there as well. The Bailey 3 had some not quite controversial, but basically they ended up using a little bit too many kids that had delays in their norm comparison, and so it's not as good at picking up delay as it could be, even as much as the 2nd edition was. So this was identified a few years ago. I don't know if they've done revisions at this point, but it is a screen test. It just is going to say delay, so we would rather there be extra delay identified, but in this case it wouldn't identify all of the kids maybe that could possibly have some delay. So just something to know if you're ever at a place that uses that. Okay, so standardized tests. This is a whole list of them that we're going to go through. Some of them are norm referenced to kids with specific disabilities. Some of them are still looking at comparison to normal kids. Some of them are that more criterion reference test where you're just completing the test, you're getting a score, and then the next time you do it, you would compare the child's results to their previous score to show progress that way. But this is the list of the ones we're going to go through today. So the AIMS, or Alberta Infant Motor Scale, like I said before, it could be a screening test or a standardized assessment, and its purpose is to identify kids with gross motor delay and then monitor that progression over time. Age range is from birth through 18 months old, and then you correct for prematurity only up to 12 months of age for this one. So after 12 months old, it doesn't matter if a baby was born early, we just score them at whatever age they are from birth. And this looks at only gross motor function, but it looks at that those skills in 4 different positions: in supine, prone, sitting, and standing. And then with this test, you can get norm and criterion reference tests. So you get your raw score, which is in each area, and then all the total added up, and then you can get a percentile rank from that raw score based on the kid's age. It can also tell you if they are delayed, at what age they're functioning at on average, just based on where they fall on the graph. This is one test that we're going to look at a little bit more in depth in lab on Thursday, the second lab, I believe. So this is just a sample of the first page, so you can kind of see the layout of this test. It is a strictly observational test, so any item that a child gets a point on for this, you cannot help them do. That being said, you can still interact with the child, or if it's one, if you look at the standing ones, they see the first 3 are supported standing, so the caregiver can help support the child with those. But the prone ones, the rolling, sitting, those kind of things, they have to be able to do them independently in order to get the point. And then down in that right-hand corner is the age graph, where you look at the child's age and then how many points and plot their score on the graph, and then it gives you those percentile lines from the 5th percentile up to the 90th percentile. For this test, after a kid's about 12 months old, it's really difficult to get a good score, because if they miss certain items all of a sudden, just because you didn't see them do it today doesn't mean they can't do it, but it can really throw off their score. The best age to do this test at that it's predictive of delay down the line is about 8 or 9 months old. Once you get beyond that, you can end up appearing like you've got delayed just because a child wasn't in the mood to do all of the items on that particular day. So just something to keep in mind with this test. But again, we'll look at it a little bit more in depth in lab. The Peabody Developmental Motor Scale, 2nd edition, or PDMS, or just Peabody. The purpose of this test is to assess gross and fine motor development. Again, it's a direct observation test, so you have to see the child do the items. In order to get credit for it, you cannot just have a parent report, oh yeah, they can do that. We need to see them do it in the testing setting. Age range is anywhere from birth through 6 years or 72 months of age, and then we again adjust for prematurity up to 2 years old. The areas that it tests are reflexes, but you only look at that up until the kiddo is 12 months old. And then they have a stationary section, a locomotion section, and object manipulation, which you only do from 12 months old and older. So basically it takes the place of the reflexes section. And then fine motor areas of grasping and visual motor. These results are norm referenced, so you get a total score and you compare it to their age-matched peers. Typically, when we're doing this test, the PT will look at the reflexes, stationary locomotion, and object manipulation sections, and the OT will do the more fine motor type of sections. If I'm testing a child, I just don't do the grasping and visual motor. I only am looking at the gross motor section because of where I work. So in my setting, I work in inpatient rehabilitation hospital, OT is going to focus on those fine motor areas, and they're going to do their own assessments. They might not do the Peabody, and even often I don't typically do it because it's too advanced for a lot of my kids, or it's just not an appropriate test because, again, I know they're going to score low, but if they've got some of those gross motor skills, and maybe they're going to be going to outpatient, it's a test that an outpatient therapist could do, and so it's nice to have a starting point, maybe a discharge from inpatient that they can continue to show progress with in the outpatient area. But either discipline can do the entire test. I just don't typically do the fine motor sections. This is kind of a picture of the whole kit for the Peabody. It's got a lot of scoring booklets that come with it and specific items to do some of the assessment. Again, you've got to directly observe the child doing it in order for them to get a credit for that item. You score them either a 0, a 1, or a 2. So a 2 is they completely do that item. A 1 is they do partial parts of an item, so they get some credit for it. A 0 is they can't do it at all. In each scoring booklet, it's really nice. This test has like criteria for what to get a 0, 1, or a 2. So it's pretty easy to do it. Low learning curve for people to administer it. It's just got a lot of items in it, so you need to know the test well because some of them are repeat items. So for example, standing on one foot, a child at a certain age is only expected to do that for 1 to 2 seconds, but then they repeat that standing on one foot for up to 5 seconds, up to 10 seconds. So when you're having them test that item, you just say, stand on one foot for as long as you can, instead of going through and going, oh, now I need you to stand on one foot for longer than you did last time. So you just avoid trying to go back in circles and repeat items again and again. So in order to know where to start, it gives recommendations based on the child's age, but you have to get their lowest point where they can get 3 2s in a row, and then you continue testing them until they get 3 0s, until they fail completely 3 items in a row. So you know that they can get maximum that amount of points, and then you add it all up in the different sections and score it. And again, you don't have to do all of the subsections, you can just do some of them. The PD, or Pediatric Evaluation of Disability Inventory, is designed, it's a specific test that is for children that already have a disability that is known, whether it be physical or cognitive. The age range for this test is 6 months through 7.5 years, but it can be used for kids that are older than that are functioning at that age range. At that point, then you would just use it as a criterion reference test. Otherwise, it can be also a norm reference test comparing kids to their age-matched peers. The areas that it looks at are self-care, mobility, and social function domains. So there's lots of items in below each of those sections. You can have a caregiver fill out and say they can do this, or you can directly observe the child with each of these items. Scoring the PD is pretty straightforward. You can do it or you can't. There is no partial, unfortunately, so you get a 0 or a 1 for each item. The other thing, though, that is nice about it is if they do need assistance, you can give a caregiver assistance rating. So if a child needs max assist, they get less points than if they can do it with only min assist from a caregiver. And even if they can't do it independently, you can show progress with decreased assist from a caregiver over time. Before needing to say, yeah, they finally can do it and they can get that point all on their own. And then again, you can have the caregiver report that the child can do it or cannot, or you can have them directly do it and observe it. Some of the items, things more like toileting and eating, that you're not going to be able to do in a evaluation or a clinic setting, you have to have caregiver report. So that's a nice way to simplify things on this test. The GMFM, or the Gross Motor Function Measure, specifically looks at changes in gross motor function or skills over time. It was primarily developed originally for children with cerebral palsy, and the age range could be any range or any age, but it is validated for those kids with CP from 5 months old through 16 years old. And if you have a typically developing kid who's 5 years old, they should be able to do all the items on this test. It is specifically a criterion reference test for any kid that you're doing it with that doesn't have a diagnosis or that has a different diagnosis than cerebral palsy or Down syndrome, but they do have norm-referenced age comparisons for children through those age ranges of 5 months to 16 years old for kids that do have a diagnosis of cerebral palsy and Down syndrome. So it is both criterion referenced and norm referenced, but norm referenced only for those two diagnoses. The areas that it looks at, again, it's only gross motor function, but they look at different sections. So in lying and rolling, there's a sitting section, a crawling and kneeling section, standing, walking, running section, and jumping section. So depending on the kid's skill level, you can do one section, all of them, some of them. If you do all of them, you can get an overall score, but otherwise you can get a percent score from any of those subsections and then move on and progress as the child gets older or gets more skills. All right, last but not least, we've got the Brunick's-Ostrowski Test of Motor Development, 2nd edition. So BOT2 is what we call this. Purpose for this is assessing fine and gross motor skills, and it's much higher level balance and coordination test. It also has a really wide age range from 4 years old through 21 years old. This is a really nice test that is done oftentimes in school systems because it's that higher level assessment. So you can pick kids up a little bit earlier on that might need a little bit of help with some PT/OT stuff, keeping up with their peers. But it specifically looks at fine motor control, manual coordination, body coordination, so alternating movements, those kind of things, and then strength and agility. And it's also a norm reference test looking at comparing their skills towards those age-matched peers. The BOT2 does come with its own specific kit with items for fine and gross motor. It's got a little balance beam in there. It's got a really nice flip book that has pictures of each of the items to do. So it's one way to get the kids involved in interacting with doing the test. They like to flip the pages a lot of times. They like to see what's next, that kind of thing. In order to score and get points, you do directly have to observe the child performing the items, but that manual, that flip book, has specific directions on what qualifies and counts, and it does ask for very specific arm positions and standing positions in order to get a point. So for example, hopping on one foot is an item, but the child, in order to get credit, has to do it with their hands on their hips. If they take their hands off their hips, it doesn't matter if they hop 20 more times, they don't get credit for any of those, which is somewhat a little bit unrealistic because kids do all of these movements and they put their arms in different positions and they close their eyes or they step or they move around, but they don't get credit for it on the test because it is so specific with how they want the items done. That can tease out kids that have behavioral difficulties or challenge following commands, though. It makes it more frustrating for them. They might need multiple repetitions to try it, but that's okay. It again is a high level test, so it teases out those typically developing kids from those that need a little extra help. And again, it's frequently used in the school systems. You'll see it more often. You can use it in medically based PT, though. I've done it at Madonna with kiddos that are a little higher functioning, but oftentimes used at school system because it's going to tease out those minor deficits that other tests just won't assess or won't pick up because they're too high functioning. All right, we've made it through references page. Go ahead, write down any questions you guys have. We'll see you in class on that first day. For the second lecture, we'll go through some of these items, and if you have any specific questions, we'll try and take a look at some of those things, maybe do a little bit of demonstration. If you have questions on some of those gross motor skills or reflexes items, let me know. Bridget can get me any information and we can come prepared to discuss some of those things before we dive into the next lecture. Thanks, and we'll see you soon.